talk to you about superficial venous thrombosis, SVT or ST. I do want to thank Dr. Dio for letting me use many of her slides. I think that her presentation was one of the best I've seen in a very long time in regards to this topic. So rather they reinvent the wheel about so many great things you are. But let's see. So what is superficial venous thrombosis? We also refer to it as superficial thrombophlebitis or ST. It used to be considered benign, self-limiting condition. I think you all have been previous to patients that were treated just very conservatively without any further thought. The incidence is 1 in 1,000 with a estimated incidence of cases of approximately 125,000 in the United States alone every year. And the average age for this case is approximately 54 to 65 years old. It is more common in females, and it often involves varicose veins. What are the risk factors? Well, this should be very familiar. They really share same risk factors for the most part with DVT. So history of sclerotherapy, history of previous DVT, pregnancies, oral contraceptives, or hormone replacement therapies, obesity, long distance travel, immobilization, surgeries, traumas, malignancies, thrombophilia. However, the most common risk factor is the presence of varicose veins. 62 to 70% of SVT patients will have varicose veins, and up to 70% may have an associated superficial venous insufficiency with them. So taking this into consideration, we can start getting an image of our patients and what we're looking for, and to better diagnose and how we're going to manage them. The clinical presentation, again, this is nothing, should be nothing new, that they're painful. We see they're erythematous, they're palpable, they're low. Some of them will have a low-grade fever. Obviously, that low-grade fever can lead to the complaint of malaise. We do see this all the time in our post-sclerotherapy patients that can complain of very small focal areas that we tend to drain. So this presentation should be very well ingrained in your head. What's the differential diagnosis? Well, that's a little bit broader. There's a lot of things that can mimic this. Okay, we have the classic lymphangitis that streaks depending on where it is. Obviously, the history would help you elucidate that a little bit further. You have classic cellulitis, mosquito bites, but own venous insufficiency, patients with a pretty advanced venous dermatitis and inflamed veins sometimes can be confused whether they are thrombosed or not, and they require the ultrasound. Now, erythema nodosum, if you've seen these cases, they have this little tender, hot, warm nodules. You can say, well, that might be an SVT. And you do need the ultrasound to fully exclude these cases. So within that clinical presentation, we look at the locations that can really happen in almost everywhere, upper, lower extremity, breast, chest, dorsal vein of the penis. But the most common locations are the lower extremity, and within that, the GSV and tributaries, and then the upper extremity, the cephalic and basilar veins. Unusual presentations are that of Mondor's disease. Okay, this is a rare entity of thrombophlebitis affecting the thoracoepigastric, lateral thoracic, or superior epigastric vein, and that presents with the chest area as seen in the lower picture. And when the inferior epigastric vein and its branches are damaged, it can appear over the groin or the dorsum of the penis. Okay, so these are pretty clear. You should just put this in the back of your head as Mondor's disease. Okay, this can come up at any time in a test or quiz. Then there's Trousseau's disease. Trousseau's disease is a migratory thrombophlebitis that is associated with malignancy. The key part here is migratory. These patients will have this sort of progressive a migration of thrombus up their limb. And unfortunately, it is associated with, most common with pancreatic cancer. So these patients already have a very poor prognosis from their cancer, and then they have these other additional complications. Another presentation of SVT is that of a suppurative superficial thrombophlebitis. When it gets infected, it's not bueno. All right, these patients need antibiotics. They need surgical management. They need to be drained. And the image here just shows you that vessel before and after drainage. But these are sick patients. So superficial venous thrombosis. So what's the classic etiology of it? Okay, we have the Virchow's triad that we're so familiar with, the endothelial injury, the stasis, the hypercoagulability. But now we know that varicose veins, chronic venous insufficiency, and some data demonstrating that inflammatory mediators may really put you at a higher risk for the development of these SVTs. So they're so different, so similar. So why we're looking at them in its own kind of separate bucket? Well, SVTs and DVTs do share the similar risk factors, age, obesity, cancer as mentioned, but unlike DVTs, the main risk factor of an SVT is a varicose vein. Okay, so if you have a patient with varicosities, they have a higher risk factor of SVT. Thankfully, that SVT has a low 3-month mortality, which is 5%. Then we look at 3 months for a PE, that's 9 to 17%. So how does this matter? Well, we have Shingales in 1996 that looks at 236 patients with SVT and no concomitant DVT at the time of diagnosis. They follow them for 1 week with an ultrasound with 1 week later and demonstrated progression to a DVT in 11% of those patients. 16% of those patients had proximal GSV SVT extending into the femoral vein, with the SFJ being the most common area of progression, and proximity of the SVT within 1 centimeter of the SFJ conferred a high risk of progression to a DVT. So that not so high risk SVT can really quickly become a much more significant DVT and PE with complications and higher mortality to your patients. So they cannot be ignored. So when we move forward and we looked at the prospective observation of superficial thrombophlebitis study, or the post study in 2010, in a small French community of French hospital of community-based physicians, in which they scanned symptomatic patients with suspicion of SVT. These people took 844 patients with then confirmed SVT, and they in order to be included, they needed to be 5 centimeters in length at least. So they weren't looking at small SVTs, but 5 centimeters. And of those, 25% or 210 patients had a concomitant DVT or PE. That's a really significant number, okay? So that leaves 634 patients SVTs without a DVT or PE that were eligible for a 3-month follow-up, okay? And of those, 90% were already anticoagulated. 3-month follow-up patients, 10% of them had some form of thromboembolic complication at the 3 months. So about 0.5% had a PE, 2.8% had a DVT, 3.3% had an extension of the SVT, and 1.9% had a recurrence. So who was at higher risk factor for complications at 3 months? Well, males were. Interesting, right? Because earlier we were talking how females tend to have a higher predominance of this. Prior history of DVT or PE, previous cancer, and the absence of varicose veins. So when you look at this, it sort of breaks all the little previous rules that we mentioned, right? We had males, we had somebody, Dr. Sufyan?
Yes.
Do you mind muting? I got an echo all of a sudden. I don't know if it's you. Sorry. Hello? Okay, I think that's better. And then the absence of varicose veins, which we had mentioned that mainly varicose veins was one of the main risk factors. When I look at this data and I see, well, prior DVT, PE, previous cancer, and male, well, I'm thinking now that there might be other issues happening here, okay? Maybe with varicose veins, we know what the problem is. It's chronic venous insufficiency. But in the absence of them, then what we see with patients that seldomly develop a DVT, right, without any provoking factors, we start thinking malignancies. And I think this is sort of where you have to start seeing these things. And it's what you're seeing here is previous cancer, male, prior history of DVT, PE. So maybe malignancy, thrombophilia. These patients might not have a varicosity, but they have SVTs. And this should really light up a big light bulb on your head. So this study, when you look at the data, just has been mentioning, 20% of the SVT patients with varicose veins went on to develop a DVT. 60% of SVT patients without a varicose vein went on to develop a DVT. So those patients, again, without varicosities, had a much higher risk of morbidity and mortality from their SVT. So keep that in mind when you're evaluating your patients clinically. We're moving forward into a next study, which is a study in 2014, in which they look at concomitant DVT but asymptomatic at presentation with SVT. They had, again, a French study, and they demonstrated the incidence of DVT of approximately 0.64 in 1,000. Concomitant DVT, again, was a same as the post study, showing 25%, and concomitant PE 5%. That is not chump change, and we really need to be paying attention to these SVTs. So how do we diagnose them? How, we're already worried about them. How should we diagnose them? Well, clinically, you already know how they present, right? The pain, the hard palpable cord, the erythema, local edema, these being classic. Duplex sonography should be used to confirm the diagnosis. I think every patient with an SVT should have a duplex. You want to know what the extent of that SVT is, the size of it, and if there is any concomitant DVT. You see already that up to 25% of these patients can have a concomitant DVT, especially if they don't have varicosities. You should be really worried. That ultrasound is very valuable and so readily available. And here's just an image of a GSV thrombus extending into the femoral vein at the saphenofemoral junction. Okay, I think you should be familiar with that. This is a classic thrombosed varicosity with the main GSV trunk there present. Okay, so they see a path of extension. And I post you this image, okay? So you have an SVT. You can see it from the image, right? You can see that you touch that, that's gonna be indurated, looks painful, it looks inflamed, probably was a little bit redder earlier. So then you should start thinking, all right? You should start visualizing, what are the risk factors of this patient? Where is this coming from? Is this an SVT associated with the anterior accessory saphenous vein? Is it associated with the great saphenous vein, right? If those are involved, is it extending into those? And if it's extending into those, is it extending into the common femoral vein, right? How far is it from the saphenofemoral junction? And when you look at that, well, you might find that, hey, this person had an anterior accessory GSV that was not palpable, not seen in exam. It was thrombosed, and sure, it extended in less than 5 centimeters from the saphenofemoral junction. So this patient already is showing evidence of progression and is at higher risk of developing a DVT or PE if they have not already developed one. When we look at the lower extremity, same idea. You should say, hey, what are my possible veins involved here? Is it the GSV? Is it the small saphenous vein? Are there calf veins involved? Are there perforators involved? This is where the ultrasound is a must. And here you see an occluded saphenous tributary mid-calf. Okay, you can see that externally from the prior picture, thrombose, and then a concomitant calf extending into the gastric veins. Okay, so this is what you don't want to miss. So when you look at the anatomy, at the person, think about the anatomy, think about connecting the dots. You have thrombosed varicose veins in the medial, anterior, posterior side. You start to think greater saphenous vein, common femoral vein, or medial thigh phlebitis with the GSV, progression into possibly the SFJ. When you look at an anterior lateral thigh, lateral leg, you have to think anterior great saphenous vein, GSV, to the SFJ again with common femoral vein. In the posterior calf, as discussed, SSV. About opposite veins, you think about also the rest of your calf vein. So think a bit about the anatomy. Think about what's most common. Think about what you see when we're treating these patients with ultrasound-guided foam sclerotherapy, right? Where are our greatest concerns? But we see that foam traveling in those patients. So this is how perhaps you should start looking at it. You see a short segment associated with varicose veins. Well, you have a low risk, okay? Perhaps no further workup, but I think that patient should be followed. And that no further workup to me, I think any patient with a short segment varicose veins that's thrombosed, he needs further workup. From my standpoint of view, this is sort of how the community might look at it. From us, I think that they should, once it's resolved, they should have a further evaluation for chronic venous insufficiency, what led to this, and how they can be prevented in the future. Short segment without varicose veins. Well, now as we discussed, moderate risk. You should start considering the possibility of malignancy or thrombophilia. Okay, so you want to now really consider talking to these patients, referring provider, primary care doctor, your trusted hematologist, and say, hey, I got a patient here who I am concerned for X, Y, and Z. And if he's extensive saphenous SVT without varicosities, these patients are at high risk for development of complications, okay? So you do really need to be doing a full workup in these patients. And you should be managing them to prevent the development of a DVT or a PE. So, classic management again, reduce the symptoms, prevent the extension, minimize the future of risk of recurrence, as we discussed even with the minor risk one, and prevent the DVT PE, okay? So here's another trial, the STENX trial, okay? And this trial is just important out of 2003 because it's a double-blinded randomized trial. It looks at 427 patients, okay? And they were randomized to enoxaparin subcutaneously or tenoxicam or placebo. And they looked at a DVT at 12 days, and they noticed that the placebos versus the enoxaparin, and the enoxaparin had a much higher, were much higher in the placebo, the presence of DVT at 12 days. So all I want you to get out of this is that this trial pretty much introduces the use of low molecular weight heparin as better than just the classic just NSAIDs, your aspirin, for the prevention of DVT. Now, they do not really go much into dosage or time of treatment, and we should not take any further out of this trial. Okay. So again, when we look at that management, the NSAIDs, the aspirin, well, should we really be thinking more about low molecular weight heparin, unfractionated heparin, warfarin, the use of compression stockings, or perhaps even some of the new anticoagulants, so the NOACs, okay, the 10A inhibitors. This is the next most important trial that you should be familiar with, okay? This is in the folder of all the research papers, so you should be have access to it. If not, you can ask any of us. We have copies of it, okay? So this is the Callisto study, okay, out of 2010, and the use of a 10A inhibitor, the fondaparinux, 2.5 milligrams for 45 days. It's a 2B study. So it's a randomized, double-blind, placebo-controlled trial and looks at 3,002 patients. So very nice group of patients. And they look at patients with an SVT, again, greater than 5 centimeters in length. So they used that prior data, and they say, we're going to look at these large patients that were already identified as being high risk, and we're going to treat them for 45 days with fondaparinux, okay, or a placebo. Primary efficacy outcome was going to be death, symptomatic PE, symptomatic DVT or symptomatic extension, or symptomatic recurrence. Their exclusion criteria was anybody already with a DVT, a PE, recent cancer diagnosis, a thrombus within 3 centimeters of the saphenofemoral junction, okay? So no longer 1 centimeter or 3 centimeters. And SVT post-sclerotherapy, IV line related SVT, certain renal clearances, liver disease, on and on. So these were their exclusion criteria. And this is how their baseline characteristics look. Pretty darn even study, a little bit more predominant towards females, but we know that some of, if females have more varicoses, it might be more up to having SVTs. So here are the results, okay? So the fondaparinux branch, okay, 2.5 milligrams per day times 45 days, 5% absolute risk reduction with an 85% reduction of symptomatic thromboembolic complication or death. That's where it's all very statistically significant and clinically significant as they reduce their primary efficacy outcomes. Again, the death, the symptomatic PE, symptomatic DVT, extension, and recurrence. So this is why this study is so valuable. Compare that to the placebo group, in which thrombotic complications occurred more often. SVT involved the greater saphenous vein in 92% of the patients. It extended within 10 centimeters from the saphenofemoral junction in 9% of the patients, involved veins above the knee in 46% of the patients, and if BT or SVT, 7% in SVT and 12% had occurred previously, they had recurrence. So it really kind of puts the nail in the coffin that these patients do benefit from anticoagulation. However, here's a little bit more in the results. Sorry, I'm going to talk about the fondaparinux. It's the number needed to treat, which is always very important as economics go. And the number needed to treat was 20 for their primary outcomes. And the number needed to treat was 88 to prevent a DVT or a PE. So that's not a big number. You know, if you look at some of the studies with statins, the number needed to treat to prevent an endpoint complications such as MI and other problems is much higher than this. So this is much more significant, okay? So the strengths, I think they should be fairly clear. The patients were very representative of what we see in the general clinic, large population, the first randomized trial to address the optimal dose and duration. But they use fondaparinux, which is expensive, in 45 days. So the average cost of this is somewhere between $2,000 and $7,000. So perhaps not very feasible. And they also did not compare it to anything else, such as aspirin, that it has been so commonly used. So all we have here is like, yeah, fondaparinux really helps. It has its benefits, but is it really better than just aspirin or some of the other cheaper anticoagulants? So we got to then take a look at a more recent study, the SURPRISE trial. And the SURPRISE trial is great because they do compare rivaroxaban versus fondaparinux. So now we have two 10As, but one that is more readily available, more easily administered, and better coverage. Okay, so they looked at 485 patients enrolled, in which 435 were included in the pre-protocol analysis, and said the primary efficacy outcome occurred in 3 patients, or 3% of the 211 patients. And in the rivaroxaban group, there was 2%, or 200, or 4 of the 224 patients in that group. So, and there were no major bleeding episodes in either group. So the SURPRISE trial really what tells us is that, hey, rivaroxaban is not inferior to fondaparinux for the treatment of SVTs in the terms of symptomatic deep vein thrombosis or pulmonary embolism. And it helps progression and recurrence for superficial venous thrombosis and all-cause mortality, right? And it's just another tool in our armamentarium. It is better covered. It is a pill form, more easily to administer. So that's really the key point out of this trial. So with that, then we look at what are the most recent chest guidelines, okay? So what are they telling us? Well, based on all the studies that we have, they agree that patients with superficial vein thrombosis of the lower limb that is at least 5 centimeters in length, they suggest the use of prophylactic dose of fondaparinux or low molecular weight heparin for 45 days over no anticoagulation. Seeing that SURPRISE trial, I say that you can say, hey, you can use rivaroxaban, and I would do the same prophylactic dose for 45 days. In patients with SVT, they say, who are treated with anticoagulation, they suggest fondaparinux over low molecular weight heparin, taking into account availability, cost. I think if you don't have access to fondaparinux or the other 10A inhibitors, I think you're kind of stuck with the low molecular weight heparin. But that's where the new revised chest guidelines give us. So in summary, SVTs, they are not benign disease, okay? It's really a spectrum of venous thromboembolism. 25% of these SVTs will have a concomitant DVT, and 5% will have a PE. Don't forget to examine the other leg, okay? Don't forget to ask about chest symptoms, and at any point. I think if you talk to any of us in the group, we all have seen patients in which they'll deny you chest symptoms or shortness of breath symptoms. And if you poke and probe, they'll say, well, maybe like 3 weeks ago, I felt a little short of breath. And sure enough, you send them for a CAT scan and they have a PE. Obtain an ultrasound, a venous ultrasound, and assess the deep system. I say in all of these patients, okay? It's a must. If you are outside of the clinic, if you have to get if a referring provider is asking you for advice, get that ultrasound. Also, just to rule out a DVT, obviously, but have them then come and see you still afterwards, okay? I had a recent case in the emergency department in which classic GSV thrombosis. I could feel it, I can palpate it. I got this bedside ultrasound and I saw it all the way. I knew what I was doing. I checked the cath and everything, and no DVT. But because of the hospital guidelines, I needed to get an official ultrasound read by a radiologist. My order was very specific. Ultrasound, rule out DVT, patient has GSV thrombosis. I get the report back. There's not a single mention of that SVT along the GSV. And I called the radiologist. It's like, oh yeah, they didn't scan it. So even though that was my indication, it was written in the order, they're just not used to seeing it still. They're not used to thinking about how we're thinking about it. They don't perhaps have the knowledge we have, and this is where we need to educate all providers. And so make sure that those ultrasounds are done. They're so easy, so readily available nowadays. Don't forget to reassess the patient again, okay? 7 to 10 days, okay? Get more ultrasounds. Again, they're readily available. We can do them in no time, especially in our clinics. And think about the rules of 5, okay? For treatment, more than 5 centimeters in length, okay? SVT in the varicose or GSV, or 5 centimeters from a junction, you should be anticoagulating these patients. So, and that's all I got. I'll open the forum for any questions. We're just at just over 30 minutes. So.
Hello, Eddie, can you hear me?
Yes, Dr. Zukin.
I just like to make one comment about a point you made nicely on with infected thrombophlebitis and its treatment, and you mentioned antibiotics. I want to bring to the attention of our group that there is a specific type of superficial thrombosis that is related to IV, and we used to see it in the old days, post-surgical treatment, post-surgical care of patients after major surgeries, etc. And it was actually termed by Dr. Othmeyer as third-day fever. And many times you have a patient with fever or septicemia and you don't find any other complication. There will be an area that had an IV previously, and you could find pus impact inside it. And this was termed as third-day fever by him, and it is something that one should be aware, and I don't think our group will probably find it in outpatient situation. But the reason I'm bringing it up is in this situation, it is not enough to just give antibiotics, but the actual vein with its very infected pus has to be excised.
That's correct. Thank you, Dr. Supian. And as mentioned, I mean, these patients do need surgical intervention. You cannot leave that septic vein in the body. It will just continue to abscess. Anybody else? Questions? Concerns? Joyce?
Eddie, one quick question. This is Norman here.
Yeah.
In the surprise trial, I may have missed it on your slide. For how long were they keeping the patient on rivaroxaban or
45 days.
45 days also. Okay.
Yeah.
Eddie, this is Marlon.
Yeah.
Man, I tell you, you're exactly right. There's such ignorance out there in the world outside of our clinics where we see a lot of this stuff. And how do you think we can have people understand that superficial thrombosis is more than a clinical diagnosis? I mean, I've had docs say, well, you didn't need an ultrasound for that. But, you know, the ultrasound really helps determine the extent of the problem, right? I mean, these people present with concomitant DVT. These people present with axial segments that are likely to extend. We've got evidence to say these people need anticoagulation, and a simple tributary, thrombosis is different. Do you have any ideas how we can penetrate that?
Yes, I do. The one thing I do when I want one of my patients to get anything done, inflict the fear of God on them. just let them know the bad cases. just say, hey, oh, yeah, unfortunately, we have had several patients progress to a DVT and a PE from those. We all know, we've seen all the cases. So just, we have the data. I mean, it's pretty simple. I think you just need to keep it in the back of your head. 25% will progress to a DVT, 5% will progress to a DVT, to a PE. And just let them know, hey, we have these cases, we see them all the time. And just say, hey, if you want to avoid a malpractice case, just if you don't want to be feeling bad, this is what you need to do. It's the only way it's going to work. I mean, once they put that in the back of their head, that, oh, wait a second, this is really not as benign as I was taught. That's what makes them change. And I have providers call me all the time. It's like, hey, I think I have a SVT. What do you want to do? It's like, send them right over. It's like, great, thank you so much for calling me. And I just remind them, it's like, look, just so you know. And sometimes we catch DVTs, and they're like, oh wow, it's like, I'm so thankful. I'm like, yeah, hey, and that just sort of re-emphasizes that point.
Thanks, and I think you're 100% correct.
Anybody else? All right, guys. Well, thank you so much for your attention span, your time. Fellows, if you have any questions that you do not want to do in public, please feel free to reach out to me. As I mentioned, Dr. Deal is also a super educator on this, Dr. Pathos. You please reach out to any of them. If you need copies of any of these studies, you can't find them on our cloud, let me know. All right.
Thank you, Eddie.
Have a great day. Have a good weekend. Stay safe, everybody.